So we'll be talking about post-TB lung disease in children and adolescents and why it's so important to study and focus on these young people. And primarily, it's to speak about the incredible burden of disease in young people. We don't talk about it enough, but 1.25 million children and young adolescents, so the 0 to 14-year-olds, developed TB in 2023. 1.64 million youth ages 15 to 24 in that same year. We don't know exactly the number in the adolescent age group, which we call ages 10 to 19, but overall that's nearly 3 million young people between the ages of 0 and 24. And so PTLD, as we're looking to understand the prevalence across these ages, it's really may affect very large numbers of young people across the world, and as we've said, has potential impacts for their long-term health and well-being. And when we speak about all the heterogeneous ways that we see TB play out and post-TB in adults, it's even more so the case in children and adolescents because there's such a wide variation by age in how TB manifests that might have impacts for how post-TB lung disease may present. So in the very youngest children on the left side, we see more intrathoracic lymph node disease and disseminated disease or TB meningitis in those early ages. And that transitions over the period of childhood and into the onset of adolescence, which is where we see more transition to adult-type cavitary lung disease. And of course, it's not as clean as that. We see young children sometimes with cavitations and can see more disseminated disease. In older children, it's, of course, a wide spectrum. And we're really trying to understand some of the reasons behind this. We don't have very good data, but we know that with that TB risk in very young children, that relates to the still developing immune system and immature immune system, so that we have more of the intrathoracic disease and disseminated TB. Also a very high risk of progression from the development of TB infection to acute and severe forms of TB. And then again, that later peak as we go into adolescence and young adulthood, along with the onset of puberty and hormonal changes of puberty, we see differences in how the immune system tackles TB, where we actually have a very robust inflammatory response, cavitations, and very high bacillary burden that impact cavitary lung disease and also may very well have implications for post-TB lung disease. And of course, over the life course, there's differences in the types of infections, co-infections that we're exposed to. In particular, perinatal HIV uniquely impacts young people and their TB risk and lung health. And then, of course, there's differences in behaviors and exposures over that life course, in particular with young children often being exposed to TB in their households or close community contacts, whereas in adolescents and adults, it's more often from the community. In terms of the impacts on future health, young people disproportionately experience high burdens of years of life lost after TB. So you see the red bars specifically related to their TB illness and the blue bars being post-TB effects. So in terms of years of life lost, years of disability, and disability-adjusted life years, there's really disproportionate impacts when we develop TB in early life and adolescence and young adulthood. And we don't fully know the impacts for that on future lung health. So that's an area where we really want to understand when we have TB in early childhood or as the lungs develop over the 10, 15, 20 years, first years of life, what is that impact on the future lung capacity and recurrences of respiratory symptoms? In terms of impacts on well-being, we know that TB disease and its treatment really have multiple influences across domains of well-being for young people. In particular, stigma and mental health really have significant impacts for young people affected by TB. And we really don't know yet the full extent of effects of PTLD on long-term well-being. And it was really so nice to have the young people presenting some of their stories to give us a sense of that. I'll turn it over to you.
Okay, thank you, Leslie. When we are talking about PTLD research, we often find that pediatric groups are neglected. Children are unique and they face their challenging based on age. Diagnosing TB is difficult due to its non-specific clinical manifestations and the paucibacillary nature. Residual impairment in children has many physical and psychological implications by hampering growth potential and leading to poor quality of life. Unfortunately, we don't have a universal definitions for PTLD, aggregate measurement tools, or consensus on the optimal timing for assessment, all of which significantly impede our understanding and management of this condition in children and adolescents. Moreover, children face specific age-related barriers. Their disease characteristics change with development and growth. In adolescent TB, the risk of loss to follow-up is higher than in adults, and so far, studies describing the burden of PTLD in children have been limited, even though more research has recently conducted in many countries. So, since the first IPTBS in 2019, special attention has been given to the pediatric age group concerning the impact of pediatric pulmonary TB. There is an urgent need to gather data PTLD of pediatric and also to engage family and health workers to identifying key research priorities to improve pediatric pulmonary health outcomes. And then in 2022, WHO issued practical guidelines for assessing and managing post-TB health in children, emphasizing the need for an end of TB treatments assessment aimed to identifying pediatric with PTLD. This assessment should be considered for children with severe form of PTB and for those who remain symptomatic after completing TB treatments. But however, despite all of this, many gaps in the evidence for pediatric adolescent PTLD still remains. So, an area of research that has been recognized so far, such as TB during childhood and adolescence, is linked to long-term health effect on lung function, respiratory health, growth, and quality of life, with variations in severity and prevalence based on age. In children under 5 years, TB has been associated with reductions in tidal volume and peak tidal expiratory flow, indicating early impairment of pulmonary mechanics, and this age group also demonstrates a higher risk of wheezing and diminished growth parameter. However, data on quality of life is currently lacking. These findings emphasize the significant age-dependent consequences of childhood TB and highlight the necessity of integrated long-term follow-up and support strategies that target lung health, growth, and psychological well-being in TB survivors. So for this reason, further research and care are needed for children and adolescents. Early interventions and long-term follow-up are essential. Long-term longitudinal cohort studies are needed. More study with greater number of participants may refine the true number of PTLD estimates. Standardized assessment tailored to children and harmonizations of definition, assessment for comparable research outcomes, explore prevention strategies such as early diagnosis, vaccines, and host-directed therapies, and last but not least, of course, development of PTLD guidelines for children and adolescents. So we need to adapt our interventions and strategies to address this age group through tailored education and communication strategies, approach to follow up youth-friendly models, strategy for recruitments and retention in research, and need for meaningful youth involvement. That's our presentation. To open today's discussions, thank you for your attention. I will hand over to the moderator, Sylvia Chang. Thank you.
I would like to call to the stage Prof. Simon Skaaf. He's an emeritus professor at the Desmond Tutu TB Center and the Department of Pediatrics and Child Health at Stellenbosch University. Also Naomi Walker, who's a senior clinical lecturer at LSTM and consultant infectious diseases and general medicine in Liverpool School. Then I would like to call Professor Anthony Byrne, a consultant respiratory physician at St. Vincent's Private Hospital, and Dr. Celso Cosa, who's an in-country principal investigator and chief investigator of several TB studies and managing the Mozambican NTP program. I'm just checking. Hedazar. Yes, amazing. Professor Hedazar, who's a pediatric pulmonologist and head of the Department of Pediatric Pulmonology at Red Cross War Memorial Hospital in Cape Town and University of Cape Town. Thank you for joining. Sylvia, lead the way.
Thank you so much, and thank you so much to our panelists for volunteering to participate in this hopefully interesting discussion. So I would like to open the panel discussion just by saying, as somebody who works in pediatric TB, we know that it's a neglected field, and it's particularly pediatric post-tuberculosis field. A lot of times I hear things such as, oh, well, children just get better, they recover, or, they don't really have the inflammation that adults have. Actually, what I should say is, when we're speaking, let's distinguish young children who have more of the intrathoracic lymph node predominant disease versus adolescents who start having the adult type disease. But particularly for young children, I hear this a lot. They'll just get better, they'll just grow out of it, or they don't have a lot of lung parenchymal inflammation. So I was hoping that you would all comment on this from your unique perspectives, especially Professor Scoff with your clinical experience and what you've seen. Professor Czar with your early childhood study, and Professor Walker with your immunology expertise.
Yeah, so thank you very much for the opportunity. We used to think that when we treat children, we can just treat them, and after the treatment they will be better. But what we do see is a very wide spectrum of disease. Some children have cavitating disease, some have expansile pneumonias with breakdown, and on the other end of the spectrum we have children with just lymph nodes and maybe slight infiltrates. And in general, I would think, and that is my opinion, that the children with lesser disease or non-severe disease will recover almost completely, but on the other hand, we have never looked at them specifically to see what final effect that it has on their lung development and so on. The more severe disease, certainly children develop bronchiectasis, they develop fibrosis with expansile disease, and very often we see children that have afterwards wheezing of the chest, and then the question is it due to the TB or do they have other underlying conditions? So a certain percentage of children definitely have abnormal lungs after treatment, and I usually do a final chest x-ray at the end of treatment, specifically in the children with more severe disease, to have a look what is remaining in the lungs after treatment, and to make certain that you have actually completed the treatment well. But the chest X-ray doesn't tell you everything. So we do often have to refer to the respiratory team to do CT scans and further evaluation. I think number one, to exclude that we have no active tuberculosis left or no TB disease left, but also to see what damage has been done or whether there's any other underlying disease, which is often the case.
Thanks. Thanks very much, and thank you for inviting me to be on this panel. And morning, everyone. Great to see this room packed and the interest in post-TB lung in children, which, as was said, has really been under-recognized. I think it's a more complex problem. So when we look at our birth cohort, for example, which is a birth cohort in this situated in this area of 1,000 children, and we look at the early life impact of lower respiratory tract infection, we see a profound impact on lung function and on things like wheezing as symptoms. So that's the first point I want to make. I don't think, obviously, we're focused on TB, but we shouldn't forget that early life all-cause LRTI may have a profound long-term effect, even ambulatory disease, non-severe disease. When we try to disentangle the differential effect, for example, from a pathogen like M. tuberculosis versus RSV, respiratory syncytial virus, we do see different effects. I think in the analysis that we published of 0 to 5 years, the impact of TB, and Leo Martinez is here, he can say more to it, we saw an impact in terms of a reduction in expiratory flow rates. So that's similar to spirometry in young children. It's tidal breathing, and you look at exhaled flow rates. And we saw, speaking to inflammation, an increase in exhaled NO, a measure of eosinophilic inflammation. But that was really restricted to children who had TB under a year of age. For those older who experienced TB over a year of age, in fact, tidal volume was impacted with reduction of vital volume by 5 years of age. Now, whether these effects are sustained or not, and what this is going to look like long term, we're exploring. Just 2 points that are different from RSV, for example. So the first is, if we look at baseline lung function, so lung function done in children at 4 to 6 weeks of age, because the question is, do children get TB, do children get RSV because they've got impaired lung function to start off with, which is the chicken and which is the egg? In fact, when we look at baseline lung function for TB risk, it's not a risk. But baseline lung function is a risk for RSV, for example, which is very interesting. And we see a different kind of effect from RSV. In RSV, we see sort of an obstructive airway effect emerging. I think the data that we've shown in our other TB cohorts, and that has been shown in the Gambia, has shown more restrictive pattern developing in children who develop TB. Maybe 2 other points that I want to highlight, and if we look to what are the determinants of that lung function impairment besides TB or RSV, we find that children who develop these infections, TB at a younger age, in fact have increased capacity for repair. There's a sex effect, and nutrition. Nutrition is a key component that determines how much lung function you regain. So nutrition at the time of TB diagnosis is really key. And if we look at our other TB cohorts where we don't have baseline lung function, but we follow children who have TB, children who have that's confirmed TB, unconfirmed TB, and children who have non-TB, lower respiratory tract infection, it's not a dissimilar pattern. It's predominantly a restrictive pattern that develops over time, but actually lung function in all those 3 groups improves over time, although those with confirmed TB have substantially lower function than those with non-TB, lower respiratory tract infection through time. But again, nutrition being a major component of whether there's catch-up lung growth. So I think if there are modifiable factors in all of this, nutrition seems to be a key component. Of course, there are a lot of other determinants, exposure to household smoke, maybe smoking in adolescence, those kinds of determinants. But I think overall the message is not all doom and gloom. It seems there is capacity for lung repair, and that the longer a child goes, the more the repair, as one would expect. And if you can support nutrition, you have a better chance.
So just responding on the kind of issue of inflammation and the potential for differential inflammatory responses between the very young children and older children and adults when they experience TB. I think we certainly know both in childhood TB and in adult TB that it's inflammation. But I think one of the key differences that is possibly overlooked is the contribution of protective immunity, or some degree of protective immunity, And in classical adult pulmonary TB, where we see apical lesions and cavitation and that really destructive phenotype, tissue-damaging destructive phenotype, that is adult post-primary TB. So it occurs after a period of relative immune control, where the Mycobacterium tuberculosis infection was established many, many years, if not decades earlier, and that there has been some degree of a protective immune response. But in that niche, in the apex of the lung, that the Mycobacterium tuberculosis infection has eventually triumphed, and perhaps even diverted the host immune response to its favour to allow a cavity which provides a site where high mycobacterial replication can occur, an immune-privileged site, but at a specific anatomical site. Whereas in very young children, particularly in the first year of life, for example, tuberculosis is primary progressive tuberculosis in the vast majority of cases where there's been no protective immune response and TB has disseminated. And then you may get primary disease in the lymph nodes, which may be the result of a kind of a protective immune response being established, but still causing symptomatic disease. So I think we know that there is likely to be a difference between those responses. Whether they both equally lead to long-term impairment is yet to be, I think, fully discovered. But the consequences for a developing human, in getting a significant episode of TB at that time of life, I think can't be underestimated. But yeah, I think it's really important to accept that TB involves different types of immunity, and that's why we see the spectrum of disease that we do.
Thank you. And I can't believe how little time we have left. So I think we only have time for 5 minutes. Okay, this is still going to take 5 minutes. I'm going to ask the panelists what you think are the top, maybe you can name your 1 or 2 top priorities for pediatric TB research. For Dr. Kosa, with your familiarity with the NTP in Mozambique, especially, what do you think is needed to convince NTPs that this is an important public health priority, especially given resource restraints and competing tasks?
Well, thank you for the question. Having in mind the different competing priorities for the health system, and also that, for example, in Mozambique, TB care is really decentralized to primary health care. I think that cost and cost effectiveness will be one of the most important criteria, and also simplicity to allow that post-TB care can happen where the children have access to care. Because most of the children will not have resources to go to secondary or tertiary hospitals, but will be seen in primary hospitals, and also in those settings, training, or you have staff with not high training, so you need to have methods that are simple, are cheap, and are really effective.
I think I'd just add to that and say that I think one thing that would be really useful is follow-up. So if we're not following up kids, if we're not following up adolescents or adults for that matter, we don't know what's going on. So even if there's no there's availability and limitation with testing, there's challenges of lung function testing in everyone, but particularly more so in kids. I think there's an emerging role for oscillometry. But I think if we're at least following up our patients at 6 months, at 12 months, the passage of time will give us information. The passage of time, I'm struck by one of the TB survivors there that said, I just, would hope that the TB program continues to provide care after the medications have stopped. And that could just be a follow-up appointment in 6 months. And then at least you've got the opportunity to ask, how have you gone the last 6 months? I mean, that doesn't cost too much to ask that. And if the person's been seeking care, then that's really helpful and useful information to have. I think the other challenges, just in my own more limited pediatric practice, but in private practice and in Peru, is you've got the added challenges of adolescents seeking care, not volunteering information, not volunteering symptoms, not wanting to have a medical problem. So I think that's also important.
A quick follow-up to that for Professor Scoff is when you see children, and especially you said with severe TB, how do you decide who you follow more closely after their treatment is over, and how often do you follow them? What tests do you do? And then after you comment on that, if you wouldn't mind saying your top priority for pediatric PTLD research.
Yeah, that's a wide question. Yeah, so we would usually, if you have an abnormal chest X-ray at the end of treatment, follow them up 3 months, 3 to 6 months, depending on whether they're symptomatic or not. 3 to 6 months later, and for instance, what I deal with the most is drug-resistant tuberculosis. We try to follow them up at least a year after completion of treatment to look for any recurrence of treatment, the recurrence of tuberculosis, but also for any new development of abnormalities on a chest X-ray, even though they may not be symptomatic. Yeah, I think the question about, I think in children we actually know so little about post-TB lung disease, and that there's a lot of clinical information that we still need. As I said, I think the children that have non-severe disease, do they actually have post-TB lung disease or not? And then, as I said, there are so many other infections and other conditions that affect the lungs that it's difficult to distinguish. But I certainly do think that the children with more severe disease, we need to find out exactly what the pathology is. Is it bronchiectasis? Is it bronchiolitis obliterans, which I suppose can also be due to TB? Pneumatoceles, how do they resolve? What happens to them? And the one thing that I could possibly add, which was mentioned this morning already, is in the teenagers and the children going to school, is stigma and the effect of schooling on the children, and also the schools often don't want the children back, or they don't want them back unless they're completely treated. I think those issues also need attention.
Absolutely. I totally agree. Thank you. And Professor Walker and Professor Czar.
I mean, I kind of concur on particularly the point of having a chest X-ray at the end of treatment. I think that would be something that would be universally helpful when people come back with further problems. I think we do need to do a lot more research into understanding the specific features of the detrimental immune response during TB at different ages and the long-term impacts of that. But I think in my clinical practice, not having that record of how things were when TB treatment was completed is really a difficult situation when you run into problems down the line.
I'll be very quick. I mean, I agree with everything that's said. I think we need to know more on the epidemiology and the spectrum, the drivers, and the long-term impact. And I would personally say that any child with symptoms, and we shouldn't forget the symptom of wheezing, which we find is wheezing and growth impairment. So growth impairment obviously predisposes to TB and leads to worse outcomes, but TB also has an impact on growth. So really following those children, particularly who have pulmonary or growth symptoms, I think is critical.
Thank you so much. I think that's it for our time. Thank you so much for your expertise and sharing your thoughts with us this morning.